Well, good evening. I don't have slides. I'll just do this verbally here, no visual aids. It's a real honor to follow Dr. Berwick at this meeting tonight. Thank you to the Pioneer Institute for inviting me to participate in this. It's very wonderful to be here with Tom Scully, who actually was my boss a long time ago, and a colleague also in the healthcare world when we both worked inside public service, just like Dr. Berwick did. So it's a real pleasure for me to be here to talk about these really important issues. I went to Notre Dame. That probably indicates that I'm a good Catholic, so I am going to roughly stay on topic, you know. I'm fairly obedient, you know, that's the way we are. Maybe to my detriment. But the future of Medicare and Medicaid, and I think a lot of the things I'm going to talk about will be very similar to what Dr. Berwick talked about with a slightly different perspective. First, you know, it's often said, and this was alluded to in Dr. Berwick's comments, that one might think of the healthcare system as sort of a runaway freight train, kind of going down the tracks, and it's going too fast. And Medicare and Medicaid maybe this is sort of the metaphor that's often thought of. Medicare and Medicaid are sort of attached at the end of the train and are just being pulled down this track at a very rapid rate by an engine. And so in some ways, Medicare and Medicaid really aren't the problem, so to speak. They're just part of this larger system that's going too fast and needs to be slowed down entirely. You know, the whole train needs to slow down. Now, the metaphor has a certain semblance of truth to it, except there might be a little twist, which is, what if Medicare and Medicaid were actually not at the end of the train, but we're actually at the front of the train, and we're two engines pulling the rest of the system down the track at too rapid of a rate? Then you start thinking about it slightly differently and trying to figure out, well, is there something embedded in Medicare in particular, we'll talk mostly about Medicare, that is causing this? And that's really what I want to focus on now. Medicare is a very dominant system. It's the largest payer in most markets. It's the largest single payer. Now, employers in the aggregate might be larger than Medicare in some communities. But without Medicare, really, Medicare is the payer around which the rest of the health system organizes its business. And Medicare is largely a fee-for-service program. So Dr. Berwick, I think, is right and absolutely correct in pointing out the failures of American healthcare. And there are many, and it does wonderful things for many patients, but there are problems that are pervasive, and we can see easily in the data. It's too fragmented. There's lack of coordination in many, many settings. The care is incredibly low quality in certain idiosyncratic ways. It is not, in a sense, managed by anybody, managed in a proper sense. That is, no one is watching over it from the patient's perspective in many instances, and so the care can be quite ad hoc, and lots of things fall through the cracks. That's why we have a lot of waste. That's why we have a procedure-based and utilization-driven system. And the number one reason why the system has these characteristics is actually Medicare fee-for-service. Now, what is Medicare fee-for-service? It's a claims-paying system that Medicare runs. So when a person enrolls in the Medicare program today, they can go see basically any licensed provider. That's basically the rule that's been in place for the last 50 years. And if they go and see a legitimate licensed provider at the state level, essentially the government has an obligation under the fee-for-service program to pay that claim. No questions asked. Now, Medicare has evolved over the years, really actually right from the get-go, so that when a participant gets into the program, not only are they generally in this fee-for-service arrangement, they also generally have additional insurance, because Medicare insurance is actually quite, from a certain perspective, inadequate, especially from the senior's perspective. So most seniors also have what's called either wraparound coverage or Medigap supplemental coverage, or if they're low income, they have Medicaid coverage. So the vast majority of participants in the Medicare program, which is fee-for-service, have no cost sharing at the point of service. So what you have here is a situation where the payer, the government, is essentially pretty much in the business of paying claims. Despite Dr. Berwick's efforts over the last couple of years, the main business of the Medicare program is to find whose claims that are coming in, and make sure that they're paid. There's 1 billion of them a year. There's a lot of claims coming into the Medicare program. And from the beneficiary's perspective, once they're in a wraparound plan, which most of them are, at the point of service, they actually don't have much incentive to be thinking about utilization of care. I very much agree with Dr. Berwick that most people aren't using the health system because they like to. They're there for a reason. But at the point of service, it's true that there is some, and there's lots of evidence to indicate this through lots of economic research, that if you put some cost sharing on, the use of services actually does go down. And so the question is, when you have a system where they're not paying any costs at the point of service and the government is essentially in the claims paying business, what you have is a huge incentive for volume. And then you add on top of that a regulatory system that's been put in place. Tom was a master at it. Dr. Burke, I'm sure, got very good at it in a couple years, of trying to use the regulatory payment systems to try to keep this under control to some extent. But it's by and large a losing battle, right? You're fighting against, a huge wave of claims coming in for use of services, and being able to figure out how to regulate that through the paying system, regulate it through the payment systems is very, very difficult. What it all amounts to is that Medicare has become, and this has influenced the entire healthcare system, not just those who are oriented mainly around Medicare. What it has driven is a way of delivering healthcare in the United States that has those characteristics that we find detrimental to actually high-quality, productive patient care. So Medicare is really a volume-driven system. It's fragmented. It doesn't have a lot of coordination, and it leads to all the providers that are out there that are providing services to the patients all bill Medicare separately, so they have very little incentive to work beyond their own autonomy. Now, you might recall that in June of 2009, a very famous article was written, a really fascinating article that sort of dove deep into this. It was by Atul Gawande. It was in the New Yorker. The president read it, passed it around to all his staff, and it was very influential. And what it did was it looked at McAllen, Texas. Basically, McAllen is an outlier on all of the data charts. And it was an examination of what's going on in McAllen. Why does it cost so much to take care of patients in McAllen, Texas? And the article went on to document, in a very interesting way, he's a fantastic writer, this overbuilt, procedure-driven medical system that's been built up in McAllen over the last 25 years. But what the article never said, which was, who paid for all this in McAllen, Texas? Basically, who underwrote the entire development of all this medical complex there? And the answer later was that Medicare fee-for-service did. That most of the procedure-driven system was built up around the incentives of Medicare participants in McAllen, Texas. Now, what's the next logical step, which is that there's been a lot of talk, and I think rightfully so, it's all well-intentioned, to try to break through this and orient Medicare in a different way so that the rest of the health system will move in the same direction. If you look at what was passed in the healthcare law, there's lots of discussion about delivery system reform, fixing these problems in American healthcare. And the lever they're trying to pull is, number one, through the Medicare program. In a sense, there's a recognition in the healthcare law that unless you change this dynamic in Medicare fee-for-service, all of these problems that we see in excessive cost, fragmented system of care, lack of coordination, you're fighting uphill if Medicare fee-for-service remains as it is today. And so the law says, well, let's try to get the government to move it in a different direction with different kinds of demonstration projects, the accountable care organization effort, bundled payments. There's a number of things that they're trying to move the system away from the way it's been dominated in the past. But I have a concern about this because it is putting a lot of faith in a system that I think, to put it gently, the government tends to be all thumbs, okay? And, this is also not a new idea. For the last 40 years, there have been many efforts put forward to try to move Medicare away from the dominant open-ended fee-for-service structure towards something that would be different. And there have been a lot of trials done and little incremental progress here and there. Tom proposed, in my years at OMB, he was a wizard at demonstration projects to try to push in this direction too. And I know Dr. Berwick has tried, is associated with many, many initiatives in this area. But there's a cautionary tale around this, which is what I would call the Lake Wobegon effect, right? Which is that to really get to what we call delivery system reform, really have some bite and fix the system, you have to do really one thing, which is the number one thing you have to do, which is you have to steer patients away from the high-cost, low-value provider to the low-cost, high-value provider. That's a very difficult thing for CMS or the Congress to do because they kind of tend to take a view of the provider system a little bit like the parents in Lake Wobegon, right? Everybody is slightly above average, okay? They really hate to pick between providers. And a little tale about that. Back in the early 90s, I think Tom might have been associated with this. I can't remember. He can maybe follow up afterwards. There was something called Centers of Excellence. And the basic idea was you put your toe in the water at then HCFA, later CMS, and you go around and you designate the inpatient facilities that were doing high-volume heart procedures the best, the ones that had the best health outcomes and the lowest costs and the fewest complications for the patients. So you track the claims data, you figure out which institutions are doing the best at this, and then you call them a center of excellence, right? You put your toe in the water, you call them a center of excellence, and then maybe the next year, this is unstated, of course, when it was first rolled out, but the idea, and everybody sort of implicitly understood it, was you would then come a couple years later and start steering the Medicare population away from non-centers of excellence to centers of excellence, right? And you'd get better outcomes and lower costs. A little bit like the beginnings of a Medicare PPO run by the government, okay? Well, the first announcement gets made, and this is going back 20 years now. First announcement gets made about who's going to be on the list of centers of excellence. And of course, lots of people get the list, and all the people that are not a center of excellence said, hey, wait a second. How could this possibly be? This thing is all screwed up. We're not on the list, and that hospital 200 miles away, that shabby, lousy facility that does terrible care, they're on a center of excellence, and us, the premier institution wherever, and there are a number of premier institutions, at least in their own minds, were not on the list. And so they went to the Hill and killed it, basically, and the political process. And they said, look, the data's bad. It wasn't properly risk-adjusted. We're a center of excellence. That guy down the street is not a center of excellence. So CMS really had to back off. The political system reacted very negatively to it. And why do I bring this up? I bring it up because there are lots of reasons to expect that same phenomenon to actually occur. It's very difficult for a political process to actually go and pick and choose among competing institutions, physician groups, et cetera, et cetera. What's much easier to do from a political perspective is actually just cut everybody across the board the same. Instead of trying to figure out a way to do a high-quality network, the government's default position is actually to just say, you know what, we got to hit a budget target, we're spending too much money, and the way to cut it back is to cut everybody equally, okay? And what they did in the healthcare law, yes, there's lots of discussion about moving forward in a different direction, but frankly, the big money, what really happened in the healthcare law on the Medicare side is across-the-board cuts, pretty deep ones. And they didn't pick and choose based on any quality metric. There's no distinguishing amongst any of the providers. It applies equally to everyone. So all institutions are going to be facing cuts in the future, very deep ones, based on no metric whatsoever. So that's really how the government ends up operating, and maybe it's the only way the government can operate. It's a big, complex health system, and the government's ability to navigate that, and I think Dr. Berwick basically said the same thing, the government's ability to act nimbly in that kind of environment is very, very modest. Now, I will conclude so we can get to the discussion, which is really what I think is the most important part of the program tonight, by saying, you know, there's a great point of agreement, I think, between my perspective and what Dr. Berwick had to say, which is that the fundamental question in healthcare is what can be done to bring about continuous annual productivity improvement in the health sector? What can bring about more healthcare bang for the buck on a continuous basis? Because if you don't get that, then efforts at cost control will always diminish quality. So you have to make the health sector more productive over time. Okay? That's the key. It's got to deliver more and more and more for less and less and less. That's the way most American industries operate, through a lot of competitive pressures. That's what's got to happen in the health sector. And the question is, who can bring that about? Can a governmental process lead that kind of productivity improvement in a sector as complex as healthcare? Or do you need some kind of market mechanism to make that come about? And I'm definitely on the side that you need a market mechanism, that the government's efforts in this regard may make modest progress here and there, but at the end of the day, if the government is really in charge of the resource allocation, they're going to be blunt and across the board. It won't be nimble, and you won't get productivity improvement. You'll get cost cutting. So what can do it? Well, again, I think we have to move in a direction in the Medicare program that's more like what we did in 2003. Tom was very instrumental in that, which was to enact a drug benefit that was built around competition and choice. At the time it was enacted, it was predicted it would be a failure by a lot of people because it relied on consumers actually picking a plan, not at the point of service, but in advance. Every year they have to pick the plan through which they get their prescription drugs. Admittedly, this is a lot of commodities and not services. So it's a lot less complex than delivering medical care. But nonetheless, the experience is fairly instructive, that over the last 6 years, the costs have been quite modest in terms of growth. The premium in 2012 for the program, on average, is going to be $30 a month. When it was started in 2006, it was $24 a month. So a $6 increase over the last 6 years. Not bad for a government program. And furthermore, the system has worked such that what's really happened is that seniors have been moved in huge numbers out of branded drugs into generics. If the government had tried to command that to happen, if the government had issued a rule saying, look, you have to do this because it'll save us all a bunch of money, it would have backfired. But basically, when the seniors had a premium at stake, and they had to pay more if they wanted to go into a formulary that was entirely branded drugs, their premium would have been very high, and so they picked plans that steered them very dramatically away from branded products into generics. And it saved everybody a boatload of money, including the seniors. Now, that's a small analogy. We have huge problems in healthcare that are bigger than that. I totally admit that. But we need a dynamic in the health system that can benefit from consumers picking high-value, low-cost plans. If you get the consumer wanting that kind of plan, then the provider system will follow. If the government is trying to lead the way, the provider system, I believe, will be balky at best. And let's maybe go to conversation from there. Thank you very much.